welcome. And just before we begin, I'd just like to acknowledge that my home, Quebec City, is located on lands that are the traditional unceded territory of the Huron-Wendat people. I also have a few housekeeping items to get out of the way. If you have any questions, like I mentioned before, please use the Q&A feature in Zoom. Alternatively, if you for some reason can't find a Q&A feature, you can always use the chat, but we prefer the Q&A feature, and we'll get to them as soon as we can. Even during, don't be opposed to asking any questions during if you don't understand anything. We'll try to clarify that as much as we can. A copy of the slides and a recording of the webinar will be made available to everyone, hopefully by the end of the week. So please look out for that. And if you could take a moment to complete the survey after the webinar is over, that would be great. We really appreciate everyone's feedback, and it just allows us to improve programming going forward, and keep in touch. So with that out of the way, let's get started. And on behalf of CHPCA, I'm excited to welcome Dr. Dawn Guthrie.
Thank you. Thanks so much, Nick. Okay, I'm going to start sharing my screen so you can see the slides, and we'll get everything set up here. Okay, well, it is my pleasure to be doing the second of two webinars. So if you missed the first one, not to fear, I'll do a little bit of a recap as we get started. So today we're going to be talking about understanding the challenges of caregiving in Canada. So I'm a professor at Wilfrid Laurier University in Waterloo. I'm also an INTRI fellow. If you don't know what this group INTRI is, don't worry, I'll talk about that a bit more in a second. I also want to acknowledge Nicole Williams, who is the full-time research analyst that works with me, who's responsible for any and all data analysis that you see presented today. And I also want to acknowledge the funding. So the funding for this work comes from both the Canadian Institutes of Health Research, which is our national organization that funds health services, healthcare research in Canada, and also the Alzheimer's Society of Canada. And I also want to acknowledge the team. So as part of my CIHR grant, and I know you probably won't be able to read all these names, but you will get the slides later. I just want to acknowledge that there's a great team behind me. I'm the only one here today. And you will notice, glancing through this, that we do have a really great relationship with Canadian Hospice Palliative Care Association. So I want to thank Nick and Kat and Laurel and the team there who've made these webinars possible and make everything run so smoothly. We have people from multiple parts of Canada, the US, and Belgium, and there's a whole series of research assistants that have helped with this. So this is part of work we've been doing for quite a number of years. So as I mentioned, I'm an INTRI fellow, so I'm part of this international not-for-profit research group. We have people from 37 countries around the world, and we do multinational research to develop, implement, and test standardized clinical assessment tools. And that's mostly what I was talking about at the webinar last week. So if you missed that and you want to learn a little bit more about INTRI and what we do and the kinds of data we have, that will be available at some point through CHPCA. And I also want to mention here that these tools are copyrighted, but we are always open to organizations using these INTRI tools. And I've created a link down at the bottom to the licensing information. So if your organization was thinking about maybe using some kind of INTRI tool, you want to learn a bit more, you can go to the main webpage or to that link on licensing. But these instruments are not created for research purposes. They're created to be used as clinical assessments. And then it just so happens we can also use the data for research. So as I said, they're standardized. So when you see data from across different parts of Canada, you can rest assured that the assessments are using the exact same information, collecting it in the same way, scoring it in the exact same way. They are used quite widely in Canada and globally. And so the data can be used to understand the person. first and foremost, it's a clinical assessment to understand that individual, their needs, their preferences, their goals, and to guide care planning and service delivery. But when you take all those individual assessments and kind of group them together for an organization, or for a province or for a territory, now you can start to also look at the broader picture of the healthcare system. And we have some quality indicators as well that can be used for quality improvement, again, within a given organization or program or for a region. So how are these data collected and how did I get access to them? This is a bit of a summary, but essentially the assessment's completed with a person on a laptop or a tablet, and that information is then stored somewhere electronically. And then I'm skipping a bunch of steps here just to keep it kind of straightforward, but then all of the data from across Canada make their way to the University of Waterloo. Now I'm at Wilfrid Laurier, but as an INTRI fellow in Canada, I can access the data that are stored at the University of Waterloo. And so all the researchers who are part of INTRI and our students, which is also terrific because all of my students can have access to these data as part of their undergraduate or graduate level thesis projects. So that's kind of a snapshot of how the data are collected for the person. Then they make their way eventually to the University of Waterloo. And this is probably the most important kind of single slide when thinking about INTRI and INTRI tools. So you have the assessment in the center. It's done electronically. And then what I spoke about last week is I spoke about 3 of the 4 of those applications. So it can guide care planning. The data can be used to generate health index scales, and the data that are collected can be used to generate quality indicators. And that's without any other data collection. So you do the assessment to understand that person, to guide care planning for that person, and then you can use the data for these other purposes. So that's kind of the recap of week 1. You missed week 1. So for today, I'm going to switch gears a little bit and talk about some insights from INTRI data that we have around this topic of challenges in caregiving, but also some information based on interviews. So the INTRI data are very quantitative. The items are scored typically on a score of 0, 1, 2, or maybe 0 to 8, depending on the question. We don't have a lot of open-ended type of questions. So we've also done, as part of this work to develop the QIs, we've also done some interviews. So I want to talk about that piece today as well. So I want to start out with sharing this statistic from the Canadian Institute for Health Information, or CIHI, where they quote in this short report that nearly 20,000 informal caregivers of seniors receiving home care reported distress related to their role. So this report was generated using INTRI home care data. And I've got a link on that slide to the report as well, if you want to take a look at that. So who are these quote unquote distressed caregivers? Well, this item on the home care instrument asks, is the caregiver feeling distress? Are they unable to continue in their caregiving? Maybe they've had a decline in their health and they can't continue, or are they feeling any experiencing any feelings of distress, anger, or depression? So that's who that 20,000 people represents, individuals who either felt distressed or depressed or angry or just felt as though they couldn't go on. So this is 16%. This is not a small proportion. So this is really important to know, so policymakers and planners can understand just how often is this the case in home care. And what would also be very important is knowing early on who among these caregivers might be starting to feel distress, maybe even before they get to that point of saying, I can't continue. So this is a project that I led that was funded by the Alzheimer's Society, where we were asking this question, how can we use the existing inter-eye data, so not having to collect any more information, how can we use it to know when a caregiver is starting to feel distressed or overwhelmed? And I will come clean, this was not my idea. I thought it was a fantastic idea, but I can't take any responsibility for this being my brainchild. This was actually part of a discussion group we had years ago, where some people who were working in home care said, this is something that can be really difficult for us when a caregiver calls us on the phone, say the home care program, and says, I can't continue. You need to do something today because I'm done. And they were expressing this, frustration of wishing that they had known sort of earlier who might be at risk. So we undertook a project to see if we could come up with something. So the goal was to create some kind of electronic screener to flag those caregivers who may be at risk of feeling caregiver burden, starting to feel overwhelmed or burnt out. And so it would create a score from the existing data that you already collected and kind of put people into a category based on their level of risk. So the home care coordinator or case manager, depending what province you're in, would have some insight into who was at most risk. And so we decided, okay, we're going to use inter-eye data that we already have, and we used home care data for this project. But I will tell you, you can use, inter-eye has a separate tool. So we have a tool for home care and we have a tool for palliative care. You can use this algorithm or this screener in the palliative care instrument as well. So I know this is a lot of information at first glance. So let me walk you through this, and then also you can go back and take a look at this. This is really kind of the algorithm. So it's called the Caregiver Risk Evaluation, or CARE for short. And on the left-hand side, you'll see a number of factors or characteristics of either the person or their caregiver. And then depending on how these were answered on the assessment, it puts people into these 4 groups. So I mentioned Nicole Williams, who works with me. So thanks to Nicole for putting this together. It's a lot of information. So what I'll just sort of touch on is when you look at the top, who are these people whose caregivers go into the low risk group? So the caregiver's not feeling distressed or angry or depressed. They don't live with the person. The caregiver could be a spouse, it could be a child, or it could be another type of relative. And they don't provide a lot of hours each week. They provide less than 7 hours. Now, contrast that with the group at the bottom. So if we go right down to the bottom in that group in red, who are these people then? What do we know about these individuals who go into the very high risk group? Well, right away, you'll see they're very different. The caregiver is feeling distressed or angry or depressed. They live with the person getting home care, and that home care client is showing some trouble cognitively with decision-making, input their memory, and so on. So again, all of this comes from the inter-eye assessment tool. You do the tool, you score it, then the electronic information's there, and the software puts everybody into one of these 4 categories. So even if maybe you're not using inter-eye tools, you're not familiar with them, or you're not using them in your organization, I think this can also be very useful in, just sort of highlighting who are these clients and caregivers who fall into these different groups, and then guiding, the conversation around what do we know about what tends to put people at risk. We know it's things like how many hours a week Is that caregiver providing care? That's important. What's the client's memory like? Their decision-making capacity, their cognitive performance, and if they've got difficulties, that plays in. Does the caregiver live with the person? That obviously changes the landscape. So even if you're not using an Inter-RAI tool, you can sort of look through this list and go, okay, these are important things to think about and acknowledge as part of understanding how caregivers are doing. So we have data from multiple parts of Canada, not every single province and territory, but quite a number of places. So I wanted to walk you through, again, using that same caregiver algorithm, but now I've pulled out just 2 groups. So there's 4: low risk, moderate, high, and very high. This slide is just people who fell into the high or very high risk group. And so I'm just doing a percent to see, what does it look like across Canada? So first of all, what you see is quite high rates in some places, like Ontario at 70%, also BC at 62%, and then quite a bit lower in Nova Scotia at 39%. So immediately you might think, well, why is this? And I'm sorry, I'm not going to be able to answer that in any definitive way today, because we have not done the analysis at this point to really tease out, what's happening in these different places. But what I can say, what we do know is home care. So these are all home care clients assessed with the Inter-RAI home care tool. We know that home care policies and programs and access is different from place to place. That may play into it. So I don't have a quick answer for that one. But what we can say with confidence is that these rates are quite high everywhere. So there's quite a high percentage of caregivers who are providing support to someone who's getting home care. Quite a high number of them are feeling distressed, or they're at high risk for caregiver burden down the road. So next I wanted to just talk about, those are just the percents. I wanted to look a little bit more closely at who are these individuals. So they're in the high or very high score on this care algorithm. And again, Nicole did all of this analysis for us, which is much appreciated. So what we can see here is that 75% of the clients, so the people getting home care, have some level of trouble with their cognitive functioning. So within the Inter-RAI tool, we have a whole set of health index scales. One is called the Cognitive Performance Scale, and these are individuals who have some degree of challenge in terms of their cognitive functioning. 65% of caregivers live with the client. Half of the clients have symptoms of depression, not a diagnosis. This is signs or symptoms of depression among the clients. We don't have data on signs and symptoms of depression among the caregivers. So this is among the clients. And about 20% of the clients have severe pain every day. So in doing this research and looking more closely at these clients, and we know the caregivers are at high risk or very high risk, we've learned a lot about the situation that is happening in home care within these families, where the caregivers are feeling overwhelmed and possibly distressed. So that's all from the Inter-RAI data that we already have. But although the Inter-RAI information, is quite broad, gives us a lot of data, what we also wanted to understand was people's experiences with palliative care. So this is where talking to individuals is really important, and you get a lot of very rich information. And it also gave us a chance to just allow those family members to have a voice and to have an opportunity to share with us what their journey was like in receiving home-based palliative care, and clearly some of the challenges. So by using both the inter-eye data and the qualitative data, which is how we would talk about, doing interviews gives us qualitative information. I think that's where we have, a lot of strength. It just gives us a much better, stronger picture of what's happening. So we interviewed 9 caregivers who were caring for someone who was receiving palliative home care. These represented multiple parts of Canada. We did try to recruit people who were receiving palliative care, and we tried quite hard across Canada, but we only ended up talking to one person who was actually the person receiving palliative home care, and then multiple caregivers. And we have written a very short little report for the e-hospice, which there's a link here. And we also wrote a peer-reviewed journal article, and there's a link to that paper as well if you want to read a little bit more detail about what we did. So all of these interviews were transcribed verbatim. In other words, someone typed out exactly what was said by the person doing the interview and by the person who was being interviewed. And we had a team of people led by Dr. Nicole Loomis, who had just finished her PhD at Laurier and led this work, since I don't have a lot of training in qualitative research. So we had a small group of people who read through all of these transcripts and then started to kind of put things into themes or, patterns that are emerging. What is it that quite a few people are talking about? And this little group of people, there was about 5 people, and I kind of sat in on some of these meetings. And so they met to talk about, what am I seeing? What do I think I'm hearing from these interviews? Where are there similarities? Where are there differences? All of that is part of that analytic process. And then all of the data were grouped into these sort of major themes that kind of encapsulate what people are talking about. And again, that paper really goes into this in a lot of detail. So these are 3 of the key themes that kind of emerged from that process. And then these boxes on the left, those titles, those are what we assigned it. So we just gave it this label, caregiver as an anchor. And what does that incorporate? Well, it incorporates people talking about, as a caregiver, being part of the team, sometimes feeling trapped by the healthcare system, sometimes not feeling respected. Bewildering system is another different theme, where there was, sometimes a disconnect between what the family expected from the home care system and what the system could really offer them. They talked about staffing. They talked about what happened in a crisis and who supported them through that, or what that was like. And they also talked about exceptional experiences, which I'll touch on a little bit towards the end of the presentation. Another key theme, was patient, caregiver, and family-centered care. So within this theme, people were talking about the psychosocial and the spiritual aspects of care. They talked about choice, advocacy, having a voice, or maybe sometimes the caregivers acting as that voice for their loved one, access to care. And they also talked about having to, trying to have a life beyond that diagnosis of whatever that life-limiting or serious illness was. So now I'm going to dig a little bit more into what we heard. So we've chosen to pull out a couple of individuals, and the names have all been changed to protect people's identity. So I'm going to talk about a couple. So this was 2 people who were interviewed together. Adele is 72. She was caring for her husband, Will, who was 73 at the time. And Will has a diagnosis of Lou Gehrig's disease, or ALS. And at that point, Adele was doing all of his care, including helping him with bathing, dressing, helping him into his wheelchair. She'd been doing this for a couple of years at that point where she was interviewed. And prior to his diagnosis, they had a very active social life. They spent lots of time exercising, volunteering, out and about, very engaged in their social network. And after his diagnosis, Will expressed, missing being able to go out and do things they'd previously enjoyed. So in a minute, I'm going to show you a little bit of what Adele and Will were talking about. But the second person that we spoke to was Norma. So she was 72. She was caring for her husband, Henry, again, not their real names, who had MS. And she had been a caregiver for a long time, 18 years at that point. And at one point during that, she had also been caring for her mother at the same time. So again, like Adele, she provided all of Henry's care. And as she said, she was always trying to sort of stay ahead of his symptoms and keep him as well as possible. Henry was in hospice as part of his palliative journey, but towards the end, he had decided and told his wife that he didn't want to die, and he wanted some medical treatment that could not be provided in the hospice. So he actually was transferred back to the hospital, which is where he died. So I wanted to give you a little bit of a snapshot of who these individuals are. And now I want to share with you some quotes of what they said to us as part of these interviews, of trying to understand their journey, what went well, what didn't go so well. Tell us, basically in your own words, a little bit about that journey. So this is a quote from Norma. "I think supporting family members at the end of life is really important. The physical care for the loved ones is really important. And there's many places that people can choose to end their life. A lot of people want to be at home. And if that's the case, because I did look at having to take him home, the thing that scared the living daylights out of me was there wasn't access to medical support on 24 hours. And she goes on to say, I was afraid, what if he wound up in real pain or some kind of critical thing at midnight? But I was scared stiff of caring for him at end of life in our home, because I didn't want to be suffering, him to be suffering and not be able to do anything." So that's a direct quote that we put in. You can see at the bottom, we put into the caregiver as anchor theme. So as the caregiver, Norma is clearly expressing how scary it was for her at times. Scared the living daylights out of me is what she said. There was a lot of fear around what might happen. And I think it's safe to say, I've certainly seen literature to support this, that many people do want to be cared for and sometimes die at home. But as she pointed out, it can then place a significant strain on the caregiver. Now we switch gears a little bit to Adele, who says it was really, really difficult because they would insist. There's times when they came to the door, well, if he's not going to go to bed now at 8:30, I'm not coming back. And they go and they leave me. This is talking about the supports coming in from the home care program. And then Norma says, the doctor started telling me how we wouldn't keep a dog alive when they're going through suffering and pain. And I said, don't do this. I know what you're saying. This is his decision. If it were mine, we would still be in hospice. So I had to, I won't say fight, but I had to defend myself against the hospital medical people. So remember, in Norma's case, her husband had been in hospice and then went back to the hospital. So she, in this instance, she really felt that her husband's wishes there seemed to be a bit of a disregard for his wishes during his last days, and she didn't feel respected in this situation. Okay, so moving on to Norma again, and this is under that theme of patient, caregiver, and family-centered care. So what did Norma say here? I never had any time until the last 2 years where I wouldn't stay with him until just as long as I could every day, just because I didn't feel that he'd get the care. And then I would advocate for if there was bigger things that he needed or questions that I wanted answered that needed a test or something, I would push for those things. And then she says, because I'd feel so guilty and awful if I put him into care for a short time so I could have a break. But the respites did help. It's amazing. The stress, the doctor's appointment, medications, proper food, all that puts on you. And just to have a week without that was bliss. So she's referring here to some respite that allowed her to have a break from caregiving. So as you can see, a lot of these quotes really point to the challenges of providing care. These are all individuals who were at some point getting palliative care in their own home. And some of the instances, I've just obviously picked some quotes out of, hundreds of pages of transcripts, but there are instances where the caregivers really did feel quite frustrated and quite disrespected at times. But I don't want to leave it there. I'd like to end on a bit of a high note, because there were times when things went very well. So I also want to talk about those, what we called kind of exceptional experiences. This idea of when things go well, it is exceptional. So here's a quote from Adele, who said, "To be honest with you, at that stage, we didn't think that wasn't the top of things in our head. We knew we would have to, but it wasn't a top thing in our head to connect with palliative care right off the bat. But it was one of the best things that we ever did." And this is Will speaking now. We did interview him at the same time. He said, and I guess you would call it cabin fever, because to be honest, we're used to going out, being out and going and doing things, and I miss that. And what the respite care has done is allowed me an opportunity whereby I can visit with somebody else and that. So it's been a real positive experience for us. And finally, I'd like to end with a great quote from Norma, who said, "And oh, the care aide. What really helped our life a lot too was in the last 2 years, we got a care aide and some care aide to come every time. And he was like an angel. He got to know Henry, this is her husband, really well. Henry trusted him. Henry didn't mind me leaving when he was with him." So I think there are a number of implications for different groups. And I want to walk through these as we wrap up. So for clinicians, if there are those of you in the audience, there's a lot of good, solid clinical information that can be gathered with these INTRI assessment tools. Even if you're not using them in your organization, I hope this has given you some useful insights, how you might be able to use the data that you have. Or if you are using INTRI tools and you didn't know about this care algorithm, it is now available to be embedded within the software. For people in the audience who are maybe in more of a decision-making role, I know that some of these numbers probably won't be news to you, but hopefully you've gained a new appreciation of how the INTRI data can support decision-making. Not only the decisions of those working with you in a clinical capacity, part of the clinical team, but also the wider decisions you're trying to make to optimize the care that's provided to individuals with serious and life-limiting illnesses. And again, I spoke specifically last week in that webinar about the QIs and how they can be really useful for a program, a region, a province. And finally, to families or anyone who's acting as a caregiver, I have to start by saying thank you. Thank you for all that you do. It is a tough and demanding role. It can be such a difficult job, and negotiating the system and navigating the system can be bewildering at times, and that's certainly what we heard. And lastly, I think for all of us, I think the key message here is that we can have hope. Even though the system can be complex, and frankly, the more I have learned about it in working in healthcare research for, I guess, about 30 years, the more I realize just how complicated and messy and complex this can be. When things line up well, when the system is functioning well and people get access to the services that they need, it can make a world of difference. So our job, I think, is to continue to work together, to learn from one another as we try our best to constantly try and improve what's happening, to try and make changes to the delivery of hospice and palliative care in Canada. But I do believe that there's hope, and certainly I'm interested and I'm committed to doing research to help. So I'll stop there and stop sharing, and happy to take any questions.
I can kick us off with a question. So the caregiver burden assessment tool, do you know of any examples or any organizations that are using it right now, or
So I'm actually involved in a project also funded by the Alzheimer's Society of Canada. I'm not leading it. It's being led by Dr. Connie Schumacher at Brock University here in Ontario. But we are actually using the CARE algorithm. So you know how I showed putting people into those 4 groups?
Yes.
And then the project is actually having the case managers act on it and then tell us what they did. So, you know, did they put respite in? Did they connect the family with some other organizations or supports? So we're just literally just working on ethics for that right now. It's a 2-year project. So in a couple of years, I could come back with an answer about, you know, how did people find it? Did this CARE algorithm work the way they thought? Was it useful? Were there challenges? What advice, you know, do you have for us going forward? So I'm very pleased that, you know, we're going to be able to dig into this a little bit more and really understand how people are using it sort of day to day.
Sandra from Saskatchewan asked why Saskatchewan was not included. I think maybe on the map there was a bit of a gap there.
There are some gaps, yes. So as it turns out, we don't have data in home care from Saskatchewan, inter-RAI data. We do have long-term care data from nursing homes, but not home care. So those gaps that you see just means that that particular province or territory has not either taken it up provincially. So some provinces have just said, we're going to use this thing like everywhere. In Ontario, for instance. Others, it's more little pockets, but what it means is we don't have anybody using the home care tool in Saskatchewan. And if anyone is interested in any of the inter-RAI tools and maybe getting a look at them or talking about them or how might we get going, please reach out. I would be so pleased to try and answer your questions or direct you somewhere else. If you're like, you know, we're thinking about it, but we don't know, and we've got questions, please send me an email. I'd be happy to talk.
I'll include your email in the follow-up message that we sent to folks who registered.
And I think it's on the last slide too, Nick. I think I put it
perfect.
on the thank you. I didn't show the thank you slide. I skipped it, but I think it's there as well. But yeah.
Okay, yeah. I guess building on that, Marlene is asking where one can access this software.
Oh, okay. There's multiple software vendors. So, and I don't know the names of all of them off the top of my head, but the software vendors have to enter a licensing agreement with inter-RAI because the tools are copyrighted. So you can't just take the assessment and just go out and make software. You have to have an agreement with inter-RAI, but I could send you a list if you wanted to email me and just say, you know, which software vendors are licensed for, and then just tell me, like, are you interested in the home care tool or long-term care or palliative care, and I could send you a list of vendors.
Perfect. Amy as well she's asking, were any of the caregivers interviewed from palliative oncology, and was there any were there differences between family medical types? So cancer versus MS versus dementia.
Cancer oncology, I'm not 100% sure. We certainly had people who were receiving palliative care because of a cancer diagnosis in amongst that group of 9. And they were all getting palliative care, but to what extent cancer was represented in the 9 more so maybe than other diagnoses. We have in these 2 examples, we have someone with MS and someone with ALS. I just can't remember, to be honest, whether the rest of them were mostly cancer or not. It's just not off the top of my head, but happy to follow up if you want to email me.
Perfect. We have Sarah is asking, there are specific supports available for caregivers for their own emotional support.
There are, and increasingly, I would say, certainly through organizations like the Alzheimer's Society. It varies a lot from place to place. So as I mentioned, this other new project that I'm part of what we're doing to start that project is just finding out. So we have 3 different provinces involved. The first thing we're doing is asking them, what is available right now to caregivers that you use, so that we can get a little bit of a lay of the land, because it varies so much from place to place and where you live. But there absolutely are programs available, and that's part of the job of the home care team, to connect caregivers with respite and other supports. The ones that I'm personally most familiar with are through organizations like the Alzheimer's Society, but I'm sure that I'm only know a fraction of what's out there. But that's part of what we're trying to learn and understand. What do people have access to, and then what do they use, and do they find it helpful?
There's a question, do we have this in BC? So I'm not 100% sure what they mean by this, but I'm sure you can figure it out.
Well, the home care tool is used widely in BC. So people can absolutely are using the InterRAI home care tool, which means you can get the care algorithm. I'm not sure where things are at with the care algorithm being built into the software. It is available for software vendors. It's been available for a little while, but that takes a bit of time to sort of trickle down, because it has to come from, InterRAI and then to the software vendors, and and they have to write the code kind of behind the scenes. So it's certainly available. If it's not there, it's available.
Okay, sorry, I just got a bunch of questions. So there's one person, Marnie, was wondering, are patient family caregivers given the brochure Edith to help with end of life in the home, just in reference to the one that was scared about end of life happening at home? And I'm not 100% sure. I'm not familiar with Edith.
No, nor am I. No, and yep, go ahead.
Marnie, if you'd like to explain more in chat, maybe we can circle back, and we might be able to answer your question then, if that's okay. Abir is asking, does InterRAI have data about ethnicity or immigration status if someone is interested in subgroup analysis? And that's actually, I was going to ask a similar question, because there's a few folks here that work in the First Nation communities as well. So would you like to expand on that?
Yes, very little, very, very little today in the existing tools. So we have questions about language, whether it be English, French, or something else. And if it is a different language, we do capture that on the assessment. There are 3 questions about Aboriginal status. Do you consider yourself Inuit or Métis, or I think it's 6 Nations are the 3 items. There is no question per se on ethnicity. in the tool. And we don't know anything about immigration status. Now, having said that, that's just what's in the INTRI tool. But when the assessors are doing the assessment, they can record any other information that they want, and they can do other assessments, and they do. They clearly do. I know in palliative care, they do other things. So the software can allow people to capture more of that information. I don't get that additional information if, as they're talking to the person, they learn more about them and their immigration status, or, if they've just come to Canada, and it would be in the clinical notes part, which I don't see. I just get the INTRI data, which has very limited information on ethnicity or ethnic background.
Mm-hmm. So circling back to Marnie with the Edith brochure, it stands for expected death in the home, and I did some Googling, and it seems like it was something put out by at least one Lynn in Ontario. It just seems like a resource for folks to just how to deal with to deal with that situation. So I don't know if you're aware if any of the patients received that kind of thing, but it seems like a decent resource for information.
Yeah, no, I'm not aware of where it's being used or how often it's used. Again, as part of that clinical decision making, we don't, after the assessment's completed, we don't know typically what happens next. So home care is put in, and we have some information on the number of hours of nursing care and those kinds of things, but we don't get that nice detail about what kinds of things were given to the person, what kinds of conversations happened with the caregiver. We're just not privy to that level of detail.
Mm-hmm. So this is a project that's done based on existing INTRI data. Do you have any other projects that are doing more with the data?
Well, I will tell you about, we have a brand new assessment for caregivers, just for the caregiver, that they can do on their own. So I didn't mention it as part of that project that I'm working on with folks from Brock University, but that's something else that we're doing. And there's a huge pilot study going on right now as we speak. I think there's about 17 countries who are pilot testing. So in other words, just giving it to caregivers. You can do it through like a Qualtrics online survey. It's meant to be self-report. So it's not meant to be like an interview, like an INTRI assessment. So we're really excited to be able to have something that, when it's clear that the caregiver is experiencing maybe some health issues or feeling overwhelmed, we will soon have a standalone INTRI tool that's just for the caregivers. And we are doing some in that project with the Alzheimer's Society. We're also using that to help those case managers sort out what are the best resources for this person and the family, because the caregivers are feeling distressed and overwhelmed. You need to address that as well.
We have someone that missed what the self-report caregiver assessment was called. Has it progressed far enough to?
Yes, we love acronyms in INTRI. I don't know if you've noticed. We love acronyms. So this one is called the SCAN. It's the Self-Report Care Needs Assessment. Self-report, yeah, SCAN, Self-Report of Care Needs Assessment. Anyway, yes. And I'm happy to, especially if anyone today is thinking, oh, we'd like to try that out. We would be delighted to add. We're just, this is one of the ways we do research within INTRI, is just get it out there. Let's get people using it. Tell us what you think. Are there questions that we should drop? Is there something missing? It's, there is that opportunity right now to use it and see what people think.
So Danielle is asking, how can we connect to start using the new tool? I assume they can send you an email.
Start by sending me an email. Yeah, let's and we can set up a time to have a conversation. It's I'm happy to sort of get the ball rolling and just then connect people with with the other individuals within INTRI. But yeah, happy to chat.
Perfect. Well, if there's no more questions, we can probably end a little early. Of course, I'll stop my ending spiel if anybody has a question at the last minute. Oh, sorry, my cat sneezed behind me. Thanks everybody for joining us. As I said earlier, there'll be a follow-up email after with oh, sorry, we do have a question, actually, one last question. Are we able to use the CARE add-on to evaluate our employees? Oh, this is from someone who works with INTRI in long-term care, and they're asking, are we able to use the CARE add-on to evaluate our employees?
By the CARE add-on, do you mean the assessment that the survey that the caregivers use, or the CARE algorithm? Because they're
what's
different.
written is add-on, so I'm unsure of what exactly is meant.
Yeah. I'm not sure how to answer it, not knowing.
Caregivers evaluation is what.
Oh, the caregiver risk evaluation, the CARE algorithm. Okay, so you can absolutely, well, let me think about that for a second. I started answering the question. There will be some items that you do not have if you're using, say, the MDS 2.0 or the INTRI LTCF that are in the CARE algorithm, because there are questions in there about hours of support given by the caregiver, which in long-term care, we don't capture that on the assessment because the caregivers aren't expected to provide care. They often do, but they're not expected to. So I'd have to go back and take a look to see whether or not we could use the CARE algorithm with long-term care data. But if you want to shoot me an email, I'm happy to take a peek at that and see if that's, we have not been asked that question. We've, basically been only people asking about sort of home care and palliative care, but not long-term care. So I'd have to put my thinking cap on about that one.
Perfect. Okay, so I think we're done. So thanks everybody for joining us. Thank you, Don, for the wonderful presentation. It's super informative. Like I said, all the information, all the slides, and the webinar recording will be available in an email after. And please fill out the survey. We really appreciate your feedback. And that's about it. I hope everybody enjoys the rest of their day. And thanks again for joining us.